Good morning and good afternoon, and thank you everyone for joining us today. This is the Brainomix webinar, Imaging the Core on Non-Contrast CT, Unlocking Stroke Insights Across Networks, hot on the heels of our recent FDA clearance of the Core Volume feature. Before I hand it over to my colleague, Dr. George Harston, who's our Chief Medical and Innovation Officer and a practicing stroke consultant in Oxford, I'd like to just cover a few housekeeping items. We would like to make this session as interactive and engaging as possible. So throughout the course of the webinar, we'll be posing a few surveys and polls where we can gauge people's reactions to some questions. And we would also encourage people throughout the webinar today to use the Q&A function that you see at the bottom of your screen to ask questions throughout, and we will try to answer as many questions as possible. So without further ado, I will hand it over to George.
Thank you, Jeff, and welcome everyone for me too. As Jeff explained, we're really excited to be sharing with you some of the data behind our latest FDA clearance for Brainomix 360 Stroke, the technology that is deployed in the US to support image interpretation for stroke patient care. And today I'm absolutely delighted to be joined by two stroke experts with different and complementary backgrounds in radiology and neurology, both leaders in the field and really pioneers in evaluating Brainomix's technology in a clinical setting, and particularly around the non-contrast CT feature, which is the focus of our webinar today. So our first speaker is going to be Kambiz Nael, Professor of Radiology or Neuroradiology from UCSF. And then we've also got Mehdi Bouslama, an interventional neurologist at Broward Health in Florida. And very honored to be joined by these two experts today. But before I hand over to our speakers, I'm going to take the opportunity just to walk you through what the technology looks like. So you really understand how the product works in terms of the interaction and what you see when you use it in clinical practice. And as a European stroke physician, or a stroke physician in Europe, I should say, I've been able to use the Brainomix non-contrast CT technology to its full capability for the last few years. And I'm absolutely delighted that this is now available and cleared for use in the USA by colleagues across the Atlantic. So I'll share my screen and show you the user interface on a mobile web user interface on a web user interface. But it's important to note that, of course, the default functionality and indeed the way that a lot of doctors use our technology is through the web, through the mobile app to view images and communicate and share information. But for demonstration purposes, I'll share the screen. So Jeff, is that presenting okay?
Yes, it is.
Great, thank you. So this is the user interface, and we're going to talk about the non-contrast CT solution. Of course, stroke imaging is commonly multimodality. It includes CT angiography, and for some centres there'll be routine CT perfusion. Some centres use MRI, but we're going to focus on the CT today. So let's just talk through the non-con CT. So this is a standard non-con CT which has been sent to one of our servers, typically gets processed within about a minute or two of being acquired on the scanner. And the first thing that happens is that the scan gets registered to a common image space. So here you can see that the scan is straightened for ease of viewing. We can window it a bit, and as we scroll through it, the eagle-eyed of you may have noticed some changes consistent with a stroke. You can see the eyes are deviated to the anatomical right. So you might have spotted a hyperdense sign in the right MCA. And indeed, this patient presented with a right MCA syndrome. So if we look at how the algorithm works, we can see the image on the right is the processed Brainomix output. Now, the Brainomix eAspects technology originally really focused on automating the aspect score, but as the technology's evolved, we do more with that. And one of the sort of key drivers of how we do more with the imaging is this core volume feature that we're going to talk about today and focus on. So on the image on the right of the screen, as you look at it, you can see the processed non-contrast CT, and you'll notice there's this reddy pink shading overlying the right MCA territory. Now that is a probability map that's output from the algorithm which underlies e-aspects, and it's based on this segmentation that the automatic e-aspect score is generated. Now, this probability map is a probability that our algorithms have assessed likelihood of early ischemic change, so early injury on non-contrast CT. So as well as being able to overlay a patient-specific aspects atlas, and as we scroll through the image, you can see how the affected regions have been highlighted in red compared to yellow. We're also able to use that map, that voxel-wise probability map, to generate a volume, and that's the feature we're going to talk about today. Now, on the regulatory cleared product, that's presented here at the top of the screen on the WebUI is 25 milliliters of the sort of the core estimate on the non-con CT. And this is a unique feature for Brainomix. Other people don't have this technology. It's patented technology, and it's a really valuable, I find, for not only assessing the extent of ischemic injury on the non-con CT, but also just helping me draw my eye to where the ischemic injury is. And if we compare to the unannotated scan on the left, you can see actually, yeah, I agree that there is some early ischemic change. There's lots of grey white matter differentiation in the right MCA territory, and there's some hyperdensity as well. So that's really helpful. We can assess the extent of injury. We can do that with a volume. We can do it with an aspect score. But of course, actually, the fact there's ischemic change there at all is also a useful notification for me to say, actually, this patient's likely to be having an ischemic stroke. There's evidence of ischemic injury. And that you can see highlighted here with this yellow box at the top of the screen, so suspected large vessel occlusion. So this is the other regulatory cleared feature that is available for use in the US that highlights, even on a non-con CT, whether or not there's a suspected large vessel occlusion. And that is based on a few features, one of which is evidence of early ischemic change on the non-con CT, this red heat map, but also we use evidence of hyperdense vessels as well to try and bring out that and identify that evidence of a large vessel occlusion. So as you can see, the early ischemic change, the core volume feature on the non-con CT within the aspects module has multiple purposes. First, it's used to derive the automated e-aspect score, which is the most validated automated aspect score available. It generates a volume of early ischemic injury, and it also identifies or helps identify patients with a suspected large vessel occlusion. Now, clearly, in practice, we will also hopefully be doing a routine CTA at least, and so we can provide that too, and you can scroll through that and you can see the LVO identified much more clearly on this whole brain MIP of the CTA. And then, of course, we have your deconvolved CT perfusion as well. We'll hear a bit more about how these stack up with non-contrast CT later on. But needless to say, this is a comprehensive suite of tools. But today, as I said, we're going to really focus on the non-contrast CT solution. So what I'll do is I'll stop sharing my screen there, and I'm very happy if people have got some questions to address those later on in the discussion. But before we hand over to our speakers, we've got a warm-up question that we wanted to share with the audience, and that is about patient selection. And what's your current practice, your most common practice for selecting patients for mechanical thrombectomy wherever you're working? And we've got 5 options. We've got non-contrast CT only. Is it CT and CT angiography? Do you occasionally use CTP as well? Or do you always use CTP, or do you use MRI? So please select your answers, and we will see what people say. Jeff, do we have a live count of the number of people who've answered this?
Yep. We'll just give it a couple more seconds, George, and we're getting
great
coming through. I'll just go there. Moment here. So here we go. Here are the results.
Excellent. So really interesting to see this distribution of imaging modalities used to select patients for treatment. And I suspect if we'd have done this a few years ago, we might have got a slightly different distribution, but a really interesting majority non-contrast CT and CTA alone, with a significant number occasionally use CT perfusion, and then a smaller number always CTP. Obviously, not necessarily a representative sample, but a really interesting insight to see the variations. And I wonder if perhaps the discussion we're about to have might inform people's practices on the basis of the technology now available. So without further ado, I'm going to hand over to Professor Nael to tell us about some of the research that he's done with the Brainomix non-contrast CT core functionality.
Okay, Jeff, can you hear me okay?
Yes, all good, Ken.
All right. Well, hello, everyone, and thanks for having me and for the opportunity to speak at this webinar. So as George mentioned, I am going to talk about the research that we've done using Brainomix for evaluation of core. So just to give you a little background on core imaging, by definition, core or ischemic core is the volume of tissue that is already infarcted, or we think that is going to get infarcted regardless of treatment. And the common ways to measure core currently in clinical practice is really to use CT perfusion or MRI to obtain the volume of core, basically. And for CT perfusion, the current standard of practice is to use RCBF less than 30%, as you can see in this patient, and you can get the volume of core. And if you are using MRI, then the ADC less than 620 is used to evaluate the core. As George showed in his slides, Brainomix has this tool that basically would evaluate ischemic changes and voxel basis, and can provide you the electronic aspect or automated aspect scores, but also, as recently was cleared, you can actually get the sum of these voxels and therefore the volume of ischemic core. So that's one way one extra way to get volume of core or core volumetric assessment using non-contrast CT. So when this was presented to us, we thought that we should use this tool against what we currently do in clinical practice, and as a result, we did these two studies. One of them using this core volume assessment from Brainomix against MRI, and in the other study against CT perfusion. So I'll spend a few minutes on each of these studies to just walk you through them and basically show what we did. So in the first study, we included 72 patients. The inclusion criteria were basically patients who had CT and MRI before treatment. We basically identify, as you know, this is not a very common way to image because we don't really use both modalities, but for a variety of reasons, these patients, they have CT, non-contrast CT or MRI done within, I would say 1 to 2 hours from each other. So the time difference between CT and MRI, that's the mean and median. That is reflected here, 66 minutes mean difference and 44 minutes median difference between CT and MRI. And the time to stroke onset are also reflected here. So we have these two imaging and MRI. We obviously use the ADC less than 620 to evaluate the ischemic core. And non-contrast CT, we basically put them through Brainomix, and we calculated the volume of core on these studies. These are the planned Altman plots of the result of our study. You can see when we included all 72 patients, you can see, this is the range basically, there's a relatively wide range of difference between them, but the mean difference of approximately 6 ml. And interestingly, when we excluded 10 patients who presented within the 1 hour, so we dropped the number to 62 hours. These are patients that they presented after 1 hour from the stroke onset. This result was significantly improved. The mean difference was 2.6, and you can see that the variability range and the planned Altman plots are also decreased compared to what we have. So what I show you here is just one example of what you can see. This is non-contrast CT. This is basically generated heat maps from Brainomix, and I give you a volume of ischemic core. And this is the MRI that was done within almost 1 hour after the CT. And you can see that, there's relatively good correlation in terms of the topography of infarction, also in terms of volume of infarction in this patient. What we found in this research was if the patient presenting within the 1 hour, hyperacute ischemic basically patients or infarct patients, the Brainomix basically underestimated the ischemic core. So you can see that in this patient is an example of you can see almost complete whiteout of the left MCA distribution. And you can see that the smaller volume of core was estimated on non-contrast CT. So those are the 10 patients that I explained in this study that we did the sub-analysis. And we identified that in this group of patients, you may actually underestimate ischemic core on non-contrast CT. I'd like to highlight the fact that using ADC of 620 that is currently used for clinical practice, there is still a chance of getting ghost core, if the patients are presenting within that hyperacute window. This was actually a UCLA study. We looked at 20 years of data, and we reported 2.2% rate of ghost core in patients who presented within 2 hours from the onset. So all of these patients, they presented within 2 hours from the stroke onset. And this is just one example of, you can see complete whiteout of the right MCA distribution. You can see follow-up MRI. The infarction was significantly smaller after successful reperfusion. So ghost core do occur with MRI also, if they are presenting within the hyperacute window, and therefore, the difference between these two should be interpreted with caution. That the hyperacute setting, you may not, we don't really know what is really the extent of infarction sometimes in these patients. So moving to the second study, again, this was assessing the Brainomix Core assessment against CT perfusion. Just to provide you a little background, the way we measure core on CT perfusion is by using RCBF less than 30%. There are other ways to do it. Max Wintermark published this paper many years ago. We used CBV less than 2. And Bruce Campbell published this study using RCBF less than 30%. This is what we really use, at least in some of the most commonly used softwares in clinical practice at this point. And how reliable this is really, I guess, depends on who you ask and what, your practice setting would look like. But I have here for you two, these are randomized trials that they did sub-analysis comparing the assessment or the performance of CT perfusion in terms of core assessment against MRI. And Mr. Clean data, basically CT perfusion wasn't great, and it misclassified ischemic core volume by roughly by 30 ml. And Stuart Primus study, on the other hand, the performance was very good, and the median absolute error was only 10 ml. So, and this is really reflected in the clinical practice, depending on what software you use. And also, there's variation between patients. So this is just one example of two different softwares here, showing, different volume, 51 ml in one software, 29 ml in other software. And, that both of these softwares here over-calculated or overestimated ischemic core and follow-up MRI. You can see that after TQ3, this infarction was only 15 ml. So that is, it's there. It's broadly, accepted. We acknowledge that limitation of CT perfusion, but having said that, that is still a very valuable tool in terms of screening patients for acute stroke. So in the second study, what we did, we basically did a multi-center study. We included stroke patients, 117 patients from 4 stroke centers. They have large vessel occlusion in the anterior circulation. They have non-contrast CT and CT perfusion. And then we use the estimated core from Brainomix on non-contrast CT against the estimated core on CT perfusion using RCBV of less than 30%, RCBF of less than 30%. And this is the result. Again, the mean difference was very small. Again, acknowledging that there is some, variation in these Bland-Hoffman plots. Good correlation, significant correlation between the volume obtained from non-contrast CT and CT perfusion in this study. And just this is just an example of two cases. You can see, in these two patients. Patient A have non-contrast CT. This is the heat maps from Brainomix, generating the volume of the core here. And then this is the concurrent CT perfusion. And this is just the follow-up MRI. In this case, again, you can see that, the estimated core from non-contrast CT. This is CT perfusion. And this is the follow-up MRI. You can see that, there's very nice correlation between this estimated core of non-contrast CT and MRI in these cases. So in summary, ischemic core assessment on imaging remains challenging. I think deep learning and machine learning techniques they show promise in improving ischemic core delineation to extract more accurate information from simple and widely available non-contrast CT. And based on the studies we've done, we've shown that this Brainomix non-contrast CT core estimation provided comparable results to what you can obtain from MRI and CT perfusion. And with that, I'd like to thank you very much for your attention.
Thank you very much, Kam. That's a fantastic overview of some of the research that you've led in various institutions over the years. And what a fantastic data set to have access to with a joint CT and MRI sort of currently. I guess for me, one of the key sort of takeaway messages is the that no definition of a core estimate is perfect. Everything has its own limitations, and in terms of gold standard. And I do wonder, I'd welcome your thoughts on whether we need to stop calling imaging biomarkers core and at least call them an estimate or some other description, because there's clearly different signals measure different things.
Yeah, that's a really good point, George. And I think, I've spent the last 10 years of my academic life looking at core, and I think I tell you, it's very challenging. I mean, you just don't know. You measure it, and different ways. CT perfusion, we thought, just maybe using a multi-parametric approach could help and kind of fine-tune the ischemic core. The problem is these images are really, what we're looking at is not really the core. There's some component of the core, right? But we're not really measuring necrosis. There's so many variables that could contribute to the assessment of this core. The time, collaterals, many variables that could contribute to this. So I think core estimating is probably what is been used most commonly, but by no means when we say we're doing core imaging, we really calculating the real true basically ischemic tissue at a time, and there's wide range of variability, as you saw in my studies, and that is an ongoing challenge.
Yes,
but it keeps us busy, so
we
don't mind it.
Excellent. Yeah, I honestly I like the it's interesting. I suppose you're measuring three different things with the three different modalities, aren't you? You've got some surrogate of blood flow with CTP, you've got restricted diffusion of water molecules on the MRI, and then presumably some measure of vasogenic edema, water leakage on the CT, causing the hyperdensity. So, interesting to think about the different pathologies underlying the imaging signals. I think it's very easy to oversimplify, and I certainly think we've seen that in the CTP world and literature, a gross oversimplification of what is actually quite a complex estimation of blood flow and overinterpretation perhaps of what it means. So really interesting to see your results. Thank you very much. In the interest of time, if we'll have perhaps a wider discussion at the end of the next presentation. But before we move on to that, we've got another question for the audience, and I'd be really interested to get your take on how confident you feel when you're looking at a non-contrast CT about assessing the extent of ischemic injury on the non-con CT. So, be honest, tell us. Nobody knows who you are. It's anonymous. So, yeah, feel free to put what you genuinely think.
And again, just to assure there's anonymity with your responses.
Yeah. But equally, we know we've got a very august group of people in the audience, so that perhaps it'll be a very high-performing group.
All right, we'll just give it a moment. Getting some good responses coming in. Okay, so here are the results.
Okay, very interesting. So quite a range here. One person clearly very confident. So I'd be fascinated. I'd love to know who that is, but we don't. But anyway, yeah, it's good. I mean, it is interesting, isn't it? I think the more stroke medicine you do, the less confidence perhaps you become that you know exactly what's going on. And so really interesting to see that distribution of confidence. And I guess maybe the follow-up question we should ask, Jeff, is how confident in your colleagues' ability to assess the extent of injury on non-contrast CT, and is it affected by the time of day? But maybe that's a subject for another day. So moving on then, I'm really delighted that Mehdi Bouslama, who has joined us from Broward Health, and we've had a long collaboration, a long history of collaboration with Mehdi, and he's published some fantastic work using the Brainomix technology, and I'm delighted he's going to share some of his experiences with us today. So over to you, Mehdi.
Thank you, George, and very glad to be here. Obviously, we've been working on research and non-con CT biomarkers for, I think, it's been almost like 10 years now. And this is like some of the early data that I'm presenting here, that when we started using the Brainomix software, and it kind of started progressively, and it stemmed from the fact that, I mean, obviously aspects is one of the gold standards in terms of like assessing I say ischemic injury and core when trying to select for thrombectomy. And we know that the scale is imperfect. Just by looking at it, it's a 10-point score. It scores like different regions, cortical and subcortical. And just looking at it, you see like the different regions are not equally weighted. And we've done like some work looking at the core variation per different like aspects, strata. And if you see here, in this graph, you could see that like an aspect of 6, the core can vary like greatly from like 5 cc's to even up to like 80 cc's. And so not all aspects are created equal. And so the other problem with aspects is the fact that, as George was mentioning in the questionnaire that we had, is if you ask different experts, if you ask different specialties, if you ask the same person at different times of the day, they're going to score it differently. And so we have moved away from just using like a subjective assessment of aspects to while now we use like automated aspects or e-aspects. And even though it's not a perfect tool, at least it's consistent in terms of like how it gives you the score, and you can confidently say there's going to be a 5 every out of the day, and it doesn't really variate. So with that in mind, we were very excited when we saw that we could also look at the heat maps and try to kind of estimate the core from non-con CT. Some of our centers don't have access to CT perfusion technology. And so just having that measure of core, whether it's 50 or 20 cc's, is very important when you're trying to kind of select patients for thrombectomies. And so what we tried to do, and this was kind of keep in mind, this was like 4 or 5 years ago. At that time, we had access to the rapid CT perfusion software. And so we tried to compare both and see how Brainomix core volume assessment compares to the gold standard at that time, which was rapid. And so we took a cohort of patients that underwent mechanical thrombectomies over a period of 4 to 5 years. We only took patients that were fully recanalized to T2C3, and then that had all imaging data set, so CT perfusion, and MRI, where we could assess final infarct volume as the gold standard. Patients with posterior circulation strokes, anterior cerebral artery occlusion, or isolated extracranial ICA occlusions were excluded. And as Cam mentioned, we used the standard RCBF less than 30% for assessing core on CT perfusion. So our primary outcome was trying to assess the degree of correlation, one between core on CT perfusion, and MRI as the gold standard, but also assessing the correlation between the two modalities. Secondary outcomes included, obviously, rates of good outcomes and how both biomarkers predicted good outcomes at 90 days. And so as you can see here, this is our kind of typical stroke cohort. So we had started with more than 1,000 patients. Almost pretty much like a third of those had successful reperfusion to K2C3, so 636, minus 100 that did not have a completed CT perfusion. And then with all the patients that had adequate imaging data set, we ended up with 471 patients. Mean age was 65. You could see here that strokes were, in terms of severity, moderate, NIH of 16, and the cores were relatively small. You could see on CT perfusion, the mean core was 2.7, and then on E-aspect volume, it was assessed at 31.4 cc's. The majority of patients, so 75% of these patients, presented within 12 hours from symptom onset, and the median final infarct volume was 22.5 milliliters. Looking at the correlation data, you could see here that the Brainomix Core measurement had a moderate correlation with the gold standard final infarct volume on MRI, and it was 0.53 was significant correlation. It was pretty much similar to the CTP core assessment, 0.42. And then when we looked at the correlation between the two software, they had a significant correlation at 0.44. And I think this was similar to the numbers that Cam presented. I think it was 0.4 in his graph. Then looking at the Blend-Altman plots showing the agreements between the core measurement, between the Brainomix software, the CT perfusion, RCBF assessment, and final infarct volume, you could see here in the panels that they kind of performed similarly. And there was no big difference between the two software. Then we tried to dichotomize these patients by early window versus late window, but then we did not see any difference in terms of how Brainomix software performed compared to CT perfusion. And then looking at the numbers again, so if we presented early, within 3 hours, 3 to 6 hours, 0 to 6 hours, or beyond 6 hours, you could see that the correlation was pretty much kind of stable across all these times. Similar performance for the rapid software, and the correlation between the two modalities was again stable, and there was no significant differences. So then looking at how these biomarkers predicted outcomes, we could see that both were significant predictors of outcomes after mechanical thrombectomies, and they did it in a similar fashion. We didn't see any signal that there was any superiority of any of the software when it came to predicting outcomes. So again, showing like one of these case samples, you could see here the non-processed non-con CT on the left. Panel B shows the processed Brainomix CT scan. C is the rapid core, and D is the MRI. This is a patient that presented with a right MCA stroke with an NIH of 17, found to have a tandem occlusion, ICA, cervical, plus an M1 occlusion, underwent mechanical thrombectomy, achieved successful reperfusion, TICI-2C, within 6 hours from stroke onset. And you could see here, this was estimated by the Brainomix software to be like 18 cc's, by the rapid software around 30 cc's, and the final infarct volume was 20 cc's. So pretty good performance for both. Obviously, the study had limitations. This is a retrospective design. Our MRIs were done after the procedure and not before the procedure. So there's always this kind of time interval between when we got the first set of imaging and we got the final set of imaging, the gold standard, and we cannot exclude that it was some infarct progression despite like successful reperfusion. So in conclusion, we could say that the Brainomix software performed similarly to our gold standard CT perfusion, RCBF less than 30% in terms of estimating core infarct volume after mechanical thrombectomy. And I think it could be used as a substitute in centers where we don't have access to CT perfusion, or we're trying to get an estimate of core to try to allow more patients to have access to thrombectomy. And with that, I want to thank you for having me today.
Thank you very much, Mehdi. That's a fantastic overview of a really impressive study. It's a really big study, and really nice that you've got not only comparison to other estimates of core at baseline, but also benchmarking against both imaging endpoints, the follow-up MRI, and also clinical endpoints as well. So really clinically meaningful. And I guess that speaks to the sort of prognostic importance of infarct volume at presentation. And I've got a few questions, if I may, just follow up specifically on that. I mean, how much do you counsel patients about prognostication based on the baseline imaging? I mean, do you, in terms of setting the scene before you, or families, patients?
I mean, it's very rare that, I mean, sometimes like when it gets to a point where like it's a large core and they're obviously the outcomes are not going to be great regardless of the treatment options. But most of the time, you can present all the data to the patient. For them, you either treat or you don't treat, and most of the patient would choose treatment at the sake of having a chance at recovery versus not doing anything and being doomed. So I feel like it's always this, like there's a fine line trying to kind of present the data, and you could tell, I mean, 30 of 100 patients end up doing well, and for them it's like, no, it's just me, and at this point it's me, and I want to get the treatment regardless. If I end up having a complicated course, that's fine. I haven't had any patients say no despite the data.
Yeah, no, absolutely. I was thinking more about the sort of counselling and managing expectations. I mean, it's sort of I find going into these things, it's helpful to be able to say, the scan looks good. The other thing I was going to ask you, Mehdi, I mean, I was really interested by the subgroup analysis where you looked at sort of pre 6 hours and after 6 hours imaging on the non-contrast CT, and whether you were surprised at the fact that the performance was very similar in the early and later time windows.
We actually did, yes. That's a very good question. Yes, I was expecting it to perform like not as well in the early window compared to the late window, just by the fact that we're using CT and as a measure of core. But it seems like it's just consistent, and just based on like CAM's data, it's like early on, like the 0 to 1 hour is where there are like a lot of discrepancies. But I don't know if that's related to the imaging modality or the fact that these guys are like super fast progressors, or I don't know. Yeah.
Okay. It's interesting anyway. Yeah, but it's I suppose reassuring to know that similar results in across the time windows. We've got some time for some questions to the audience, and I would encourage you. There's one in the chat, but which I'll come to later. And if you've got any questions, please do have a think and pop them in the Q&A now. But before we go on to that, we've got a couple more audience polls, hopefully to stimulate a bit of thought and discussion based on what we've gone over so far. So maybe it's a loaded question, but I mean, it'd be great to get people's opinion about the relative importance of CT perfusion in the current era of evidence and technology availability, whether it's become more important or less important for selecting patients for thrombectomy. So just give your thoughts on that.
There, George.
Okay.
So let's close it here.
Great. Okay, that's interesting. I think there's clearly always individual cases where these things are more or less useful, and I think generalizing is clearly a challenge. But yeah, okay, that's good to know. Mixed opinions on that. And then we had one other question as well, which I think speaks to your conclusion, Mehdi, about if you don't have availability of CT perfusion, but you want to assess the extent of ischemic injury, then tools like this can really fill that gap for hospitals where, if we're honest, actually the vast majority of stroke patients will present to a generalist non-specialist centre. In our practice, about 80%. In other centres, I'm sure it's broadly similar. And if you don't have access to high quality advanced imaging at the front door, then actually the non-contrast CT and getting more information from that and the CTA can clearly be helpful. So just out of interest, show of hands, who on the poll, do all of the hospitals in your network have access to high quality perfusion or MRI at the front door? I'll just wait for the results. And there we go. So the majority don't, and I think that's interesting. I mean, clearly we've got an interested audience, and maybe from not representative, but actually I think that is certainly in our experience true, that actually most networks don't have universal coverage of advanced imaging at the front door, and that's really been one of the drivers behind our investment in this sort of technology to support access. So, Kambiz, if you're happy, I'll share some questions with you.
Sure.
and this is a question for you, Mehdi, perhaps, about selecting patients for thrombectomy. Do you see a change just on that last point of the weighting people give to non-contrast CT and CTA versus CTP for selecting patients treatment? Do you think that the mood has changed in the country, in the US?
That actually is correct. I mean, there's a movement to try to kind of limit the number of images we get to CT and CTA, and there's a lot of data showing that just relying on CT and CTA, even in the late window, is good enough to select patients for thrombectomies. So there are a lot of centers, I think mostly academic, that are kind of moving away from getting CT perfusion. But I think there's still a role for perfusion, if you ask me, when it comes to, like, for example, a large core, like, okay, it's an aspect of two, but how much of this tissue is dead? How much of this that tissue is not dead, is salvageable? And kind of to go on to Cam's question, I think when it comes to like the CT, there are different shades of gray, right? It's all about net water uptake. There's gray that's reversible, there's gray that's not reversible. And I feel when it comes to like slightly larger cores than the 50s and 70 cc's, at least for me, when I'm trying to kind of decide whether I'm going to take the patient or not, I look at the perfusion scans to see if there's still something that's salvageable and not causing harm.
Excellent. And just to go back to your point about choosing patients for selection or excluding patients for treatment, I mean, do you think there's a risk of using imaging too much to exclude patients for treatment? I mean, is there a in an era where we've got more and more data available, what are your thoughts on inappropriate exclusion based on imaging?
I mean, I think that's the fear, right? That's the problem that we had when we let's say we get CT perfusion early, within 6 hours. Technically, guidelines say, like, as long as you have a reasonable aspects and a proximal occlusion, you should take. So the fact that you're getting a perfusion scan, how much added value do you get out of that? Probably not much. But if you see a perfusion scan with a completed infarct, it's hard to unsee, and it's only used to exclude patients. So I think if it's in the early window, it's pretty easy to say we don't need CT perfusion, except for these cases where like they're outside the guidelines. For example, like low NIH patients with an M1 occlusion,
yes,
but like a big penumbra, yes, they need to go. Patients with isolated cervical occlusions, yes, we need it. But I feel like for these easy, straightforward cases, most of the time getting the perfusion is not adding much, but also used against the patient. Is only used to kind of exclude patients for treatment. I like to think about getting more imaging is to basically include patients and try to take them to the angio suite rather than just like exclude them for treatment.
Okay, excellent. Thank you. And I guess, Cam, I'm interested in your perspective I mean, you're obviously an expert neuroradiologist, but I think tools like this, do you think there's a value or an appeal to radiologists in other hospitals, perhaps, or even your own, to help support the interpretation of non-contrast CT?
Yes, I think so. I mean, some of these cases that I show you, if you look at them, you may not even notice the extent of injury. So I think having a tool, it's like CT perfusion, right? I mean, for the same reason that you can actually get more information from CT perfusion. If you have a way that to get more information from your simple non-contrast CT, I think that is definitely valuable, and people would welcome that. So I think this tool would, providing the extent of core, not only just aspect, right, but I mean actually telling you how much core you have. I think that that's definitely valuable. We also, again, that's maybe not in general practice, but there are some cases, depending on where you practice, some institutions, mostly academic, that they're really interested in it. Like the neuroprotective trials are coming in, and I think if you can get sometimes these patients, they don't have MRI at the beginning, right? They may not even have CT perfusion, so it's not uncommon for patients to come in, they get non-contrast CT, CTA, and then they make decision, as Mehdi said, to take the patient to angio suite. But if there is information from this non-contrast CT that you can estimate the ischemic core volume, this volume could be valuable in terms of following this patient over the course of neuroprotection, because you need to have that volume of the extent of ischemic injury in order to kind of like evaluate the effect of neuroprotection. Again, it's not a general widely accepted practice right now, but I think neuroprotection is coming back, making a lot of noise. So I think for that reason also, this tool could be very valuable, at least for what I'm trying to do. Yeah.
Yeah, no, absolutely. I think we see at Brainomix, we not only support clinicians in the US and Europe in terms of deployed software, but we also do a lot of studies with pharma partners, and absolutely that sort of parenchymal imaging at baseline, assessment of the extent of injury to be able to track change over time is something that we are we actively offer and gets a lot of interest, because you're right, if you're looking for signals of efficacy, that's clearly important. I'm aware we've got to the end of the time we've got available much quicker than I had hoped, or seems much quicker than I hoped, but such is the way with these things. So I will just, if that's all right, just close up here. We've got loads of questions in the chat, and thank you for submitting your questions. I will try and type some answers, particularly the more technical ones, for those that we haven't managed to cover in the discussion. Thank you, though, especially to our two guests today. Mehdi, Kambiz, it's been absolutely fantastic to have you share your experiences of validating the Brainomix 360 eAspects Core Volume feature. And we look forward to more users in the US enjoying this technology now it's cleared for use. So with that, I'll hand back to Jeff.
Great. Thank you, George. And thank you again, Cam and Mehdi, for excellent presentations and a very robust discussion. And thank you, everyone, for joining us today. We've had a great turnout, and clearly people are excited about this new functionality. So continue to follow us at Brainomix for future webinars and future discussions, and enjoy the rest of your days. Thank you.
All right. Thank you.
Thanks.
Thank you.
Bye-bye.